Welcome to Endocrine Wellness. My name is Dr. K. I started making these videos mainly to serve as a reinforcement for my patients that I see in the office with these medical issues. But I'm also hoping this would be useful for people out there with similar medical issues. Obviously, this is not personalized medical advice, and I would recommend that you discuss with your physician or provider regarding your specific treatment plan. Today, the topic I'm going to talk about is hyperthyroidism. What is hyperthyroidism? Hyper means excessive and above. So hyperthyroidism is where your body makes thyroid hormone in more quantities than what your body needs. Let's talk a little bit about the thyroid gland. The thyroid gland is a small butterfly-shaped gland at the base of our neck that makes thyroid hormones, namely T3 and T4. The thyroid is made up of a group of thyroid follicular cells that make a protein called thyroglobulin, which combines with iodine to make the T3 and T4. These thyroid follicular cells have a receptor on them called TSH receptor, or thyroid stimulating hormone receptor, which is the receptor where the signal from the pituitary attaches to and controls the production of thyroid hormones. So the pituitary, which is the master gland in your head, produces a hormone called TSH, thyroid stimulating hormone, which attaches to these thyroid follicular cells and regulate the production of thyroid hormones. When normal amounts of thyroid hormone production is reached, it sends signal to the pituitary, so the production of the thyroid stimulating hormone is regulated. As a result, in a person that has normal thyroid function, when you measure their blood work, they have a normal TSH, which is the pituitary control of the thyroid, and a normal T4 and normal T3. Why is the thyroid gland so important? The thyroid hormone controls not just one or two organ systems, but multiple organ systems throughout the body. To name a few, it controls body temperature regulation, metabolism in your body. It has very important role in heart function, brain function, digestion function. So when your body produces excessive quantities of thyroid hormone, all of these functions can be significantly impacted. What are the symptoms of hyperthyroidism? The symptoms can be highly variable from a person having multiple different organ systems affected to some having very minimal symptoms. So to make it easier to remember, I'm going to go from head to toe. So starting with the head, brain function, it makes the thoughts very racy. They can have a lot of anxiety, difficulty focusing, memory issues, difficulty sleeping, difficulty initiating and maintaining sleep, a lot of emotional issues. Coming down from the head, in certain patients with certain type of hyperthyroidism called Graves' disease, they can have Graves' eye disease, which is basically inflammation behind the back of the eye, and they can manifest as anywhere from mild redness to significant prominence and protruding of the eyeballs. We call this Graves' ophthalmopathy. Because the thyroid is involved in the underlying pathology, the thyroid gland can often be enlarged, and depending on the pathology, it can be diffusely enlarged or just some areas being enlarged, which we can palpate on physical exam as nodules. It can affect your heart function, where everything is going fast, so patients can present with heart palpitations or racing heart. Sometimes it also presents as not being able to catch their breath, especially when they're trying to do stuff on exertion. It can affect the digestive function, where everything is going fast. Again, they have diarrhea, frequent bowel movements. It can affect the ovarian function, so presenting as irregular periods or even having issues with the fertility. And in their legs, they can present with leg swelling overall. There's a specific condition called pretibial myxedema, which is a very specific condition that's seen on the top of your shin, with a certain type of swelling, very consistent with Graves' disease. In addition to this, overall the metabolism is high, so they have significant weight loss, increased appetite. They just feel very jittery and anxious overall. What are the different causes of hyperthyroidism? The most common cause is Graves' hyperthyroidism. The second most common cause is toxic nodule or toxic multinodular goiter. And then the third cause is thyroiditis, which is inflammation of the thyroid. So going back to Graves' disease, it is an autoimmune condition where your immune system produces antibodies that attack the thyroid and make the thyroid produce lots of thyroid hormones. Normally, your immune system is supposed to attack and develop antibodies towards bugs and viruses and bacteria. In this case, with certain individuals in certain predisposing situations, your immune system starts producing antibodies against its own thyroid follicular cells. So the whole thyroid is involved in the process of overproduction of thyroid hormones. In toxic nodule, there's a little area of the follicular cells, or a little group of the follicular cells that become hyperactive and start making thyroid hormone production. We call that a toxic nodule or a toxic adenoma. And you can also have multiple areas within the thyroid tissue doing that when we call it toxic multinodular goiter. With thyroiditis, which is inflammation of the thyroid, there's not an overproduction of thyroid hormone like it happens with Graves' disease or toxic nodule. This is just quick release of the stored thyroid hormone. There is no overproduction. So an infection or certain medication causes destruction of some of the thyroid follicular cells. They're inflamed and they just release a bunch of the stored hormones. But this condition is usually self-limiting. There are different reasons why patients develop thyroiditis. The most common cause is after a viral infection or like a cold that causes the thyroiditis, but this is usually self-limiting in a few weeks. Sometimes after pregnancy, we call it postpartum thyroiditis. There's also inflammation of the thyroid. Some of these patients can go on to develop long-term hypothyroidism, low thyroid. But in the context of today's topic, it can also be a source of thyroiditis. Certain medications, especially amiodarone, which is used in the treatment of atrial fibrillation, has a large amount of iodide content in it, which causes also destruction of the thyroid and causes thyroiditis. In certain cultures that consume a lot of iodine, I've had a few patients over the years with certain Asian cultures and South American cultures, they consume seaweed as part of their day-to-day routine, which can sometimes be an iodine overload and can trigger a type of thyroiditis, or even in a predisposed individual for Graves or toxic nodule can trigger those. So how do we diagnose hyperthyroidism? Of course, we look at the symptoms, which often gives us a clue, but the labs will definitely confirm hyperthyroidism. So like I talked about earlier, there is elevation of T3 and T4, which are the two main thyroid hormones. And because there's so much T3 and T4 circulating in the system, there's a negative feedback that goes to the pituitary. The pituitary sees that there's a lot of thyroid hormones floating around, the thyroid's hot. So the pituitary says, okay, I'm going to stop stimulating the thyroid. So it stops sending TSH to the thyroid. So on the blood work, you see a low TSH on the blood work. The low TSH is more remarkably suppressed in terms of Graves' disease because the entire thyroid is hyperactive. So there's a lot of T3, T4 circulating around, which causes significant suppression of the TSH. Whereas with toxic nodule, there is TSH suppression, but it's not as severe generally as Graves' disease. With thyroiditis also, the TSH is suppressed, but usually not to the extent we see in Graves' disease. Then we look at antibody testing. With Graves' disease, there are specific antibodies called TSH receptor antibodies that are elevated, And when they are detected in the blood work as being elevated, it can be conclusive for Graves' disease. In the case of toxic nodule or thyroiditis, these antibodies are usually not present in the bloodstream. Sometimes we also use ultrasound to look at the thyroid, and in Graves' disease, the entire thyroid is enlarged diffusely. There's increased blood flow and inflammation noted. In toxic nodule or toxic multinodular goiter, we either see one nodule or we see multiple nodules as possibly causing the hyperthyroidism. And in thyroiditis, there's typically just evidence of inflammation and increased blood flow. The thyroid size is not as significantly enlarged as in Graves' disease. The next test we also use to differentiate between the different causes and also in a way to confirm the diagnosis is thyroid uptake scan. So this is based on the concept that the thyroid is the only tissue in the body that will pick up iodine and use the iodine to make thyroid hormones. So when we present the body with some radioactive iodine, the reason we do radioactive iodine is because it'll light up on the test. So when the body is presented with radioactive iodine, the areas of the thyroid that are hyperactive will pick up the iodine at a much higher level than normal, and we are able to measure it on the test. So there are normal values established for normal uptakes of iodine on this test, and it's supposed to be under normal circumstances uniformly uptaken and within the normal values. With Graves' disease, because the entire thyroid is hyperactive, the entire thyroid picks up a large amount of iodine. On the scan, it looks high uptakes diffusely present throughout the gland, and the measurements on the uptakes are well above the normal limits. With toxic nodule, you see the iodine uptake just in that one particular area of the nodule as an intense uptake compared to the rest of the client, or if the patient has multiple nodules that are uptaking iodine, as in toxic multinodular goiter, you see multiple areas of intense uptakes of the iodine, and then the rest of the gland has normal or less uptake. In thyroiditis, because there is not necessarily an overproduction of thyroid hormones, and in fact the thyroid follicular cells are very inflamed and just trying to heal, they do not uptake any iodine, and so you get low uptakes on the thyroid uptake scan. This is a very differentiating picture because if you look at the blood work of all the three, whether it's Graves' disease or toxic nodule or thyroiditis, the blood work all are going to have low TSH, high T4, and high T3. But the uptake scan tells me there's low uptakes, then it points towards the thyroiditis diagnosis. How do we treat hyperthyroidism? First, we'll start with medical treatment. We use medication called methimazole or propylthiouracil, we call it PTU. These medications block certain steps in thyroid hormone production so that we block the steps and therefore we decrease the amount of thyroid hormone being produced. The goal with this treatment is to block just enough so we still have a normal level, but not block it too much so the patient will have hypothyroidism. These medications are commonly used, fairly safe. You do have to monitor some labs like liver enzymes and blood count in these. While patients are on this, there are rare side effects of liver enzymes being elevated or these medications suppressing neutrophil production, which is very important for immune system. Therefore, these needs to be monitored. We also use beta blockers like atenolol or propranolol to mainly slow down the heart rate and treat some of the symptoms of hyperthyroidism. The beta blockers do not really treat the underlying disease, but more the symptom manifestation. The second treatment is surgical removal of the thyroid, a total thyroidectomy, or half hemithyroidectomy, depending on the situation. In Graves' disease, we usually recommend total thyroidectomy. I often have patients ask me, why can't I just have half the thyroid gland removed with Graves' disease? It doesn't work that way because the entire thyroid is hyperactive, and you remove one side, the other side is still hyperactive. So in Graves' disease, we do have to remove the whole thyroid gland if we want to consider surgery as a treatment option. With toxic nodule on, let's say, one side of the thyroid, we can treat that patient with just hemithyroidectomy, just remove one half and leave the other side, and that is a treatment in this situation. With hemi or total thyroidectomy, the complications from surgery are minimal in the hands of a good surgeon, and usually I work with very experienced endocrine and general surgeons that have done a lot of these thyroid surgeries. The main complications, which are pretty rare this day and age, is mainly what to worry about is damage to the vocal cords and damage to the parathyroid glands. Parathyroid glands are tiny glands located next to the thyroid that control calcium levels in your body. So it's very important to protect those parathyroid glands during this surgery. The third treatment option is radioactive iodine treatment. And with radioactive iodine, similar to the test I talked about with the thyroid uptake scan, the patient is presented a radioactive iodine isotope, and this isotope is different from the one for the uptake scan. The uptake scan uses isotope to just light up the tissue, and this isotope used in treatment will destroy some of the thyroid tissue, so we treat the underlying hyperthyroidism. With Graves' disease, the entire thyroid picks up the radioactive isotope and is destroyed, so there's no hyperthyroidism. In toxic nodule or toxic multinodular goiter, often just the areas of the gland that are hyperactive will pick up the iodine. So the end result with radioactive iodine treatment of Graves' disease is this patient will eventually need long-term thyroid hormone replacement. In toxic adenoma or toxic multinodular goiter, they may or may not require, because there may be enough normal tissue left to resume normal function, but they may also need long-term thyroid hormone replacement. Going back to surgery again, when they get a total thyroidectomy, these patients will need long-term thyroid hormone replacement as well. When only half the gland is removed, they may or may not need long-term thyroid hormone replacement. In certain specific patients with Graves' disease that have the Graves' eye disease, you do need to work with the ophthalmologist to make sure that it is okay for that patient to receive radioactive iodine treatment, if that's what the patient's treatment plan involved. Because in certain situations, radioactive iodine treatment can often exacerbate and worsen the Graves' eye disease significantly. And that's it today for hyperthyroidism. If you find this information useful, or you think a friend or family could benefit from this information, please share the video. Please like and subscribe to the channel. If you have any more questions on this topic, please email the channel and I will try to answer them as soon as possible. Thank you for being here.